Hello, everyone. On behalf of the Lung Health Foundation, I'd like to welcome you to the second in our Breathe Change Policy series on accelerating lung cancer care, a call to action. My name is Jess Rogers. I'm the Vice President of Programs, Research, and Public Affairs here at the Lung Health Foundation, and your host for today's discussion. Before we begin, we'd like to acknowledge our commitment as the Lung Health Foundation to the recommendations of the Truth and Reconciliation Commission. We acknowledge that the Lung Health Foundation office in Toronto, Ontario, Canada, is located on the treaty lands and territory of the Mississauga of the Credit First Nation, as well as the traditional territory of the Huron-Wendat and the Haudenosaunee people. We acknowledge this land because it is important to remind ourselves that we are working on behalf of all Canadians, including Indigenous peoples who have been and continue to be negatively impacted by Canada's colonial history. It's impossible to have valuable conversations about lung health in Canada without connecting these conversations to the harms done to Indigenous communities. To this day, Indigenous peoples in Canada face health disparities and poor lung health outcomes. Lung cancer is no exception. While we continue to learn, the Lung Health Foundation is committed to doing our part in reducing these health disparities and enhancing the healthcare system to meet the needs of Indigenous communities. Next slide. So in terms of who we are as the Lung Health Foundation, we're the leading charity dedicated to improving lung health through a uniquely integrated approach. And so what does that mean? We do a lot of different things, but the key thing is that we integrate the things that we do to have the greatest impact that we can. So we identify gaps and we fill them by developing a research agenda and strategically investing in groundbreaking research. We just relaunched our research program this year with a number of calls already out there. And we have another call coming out in June around additional research projects across the lung health space. We drive policy, system, and practice change. We invest in urgently needed programs and supports directly for the people that are living with lung disease, lung conditions, and the people that care for them. And we promote awareness about lung health issues that affect everyone. But most importantly, we take a person-centered approach in all that we do, which means we engage, we listen, and we act based on what we hear from the people across Canada that are living with lung disease, some of whom you're going to meet today. Next slide. So just a couple of quick examples to kind of like drive it home for you. If we take our research portfolio that we undertake, I've mentioned that we launched our research program. We also have a very exciting current call out where we've partnered with a number of different organizations, including Lung Cancer Canada and the Association Pulmonaire de Québec, to directly address health inequities in non-small cell lung cancer. We did this project last year. Dr. Juergens is a recipient of one of those awards. We're really looking forward to applications that will be coming in over the spring. The support programs that we have in place for people living with lung health issues, including those with lung cancer, our support groups, our virtual fitness for breath classes, a peer-to-peer network where you're linked up with mentors that have lived through lung cancer or living through lung cancer, direct support from our team of healthcare professionals that we have at the Lung Health Foundation, and many tools and education sessions similar to this one that we're undertaking. In terms of how we try and raise voice and advocate for people living with lung health issues, we do drug submissions on behalf of people living with lung disease to CADTH. We are always recruiting advocates, like those that you're going to meet today, to join our committees, to join our advocacy efforts. We do federal and provincial advocacy days, and of course, forums like this one. Next slide. So today is about advocacy and activation. Our policy forums are the place where we want to be able to bring healthcare professionals, researchers, policymakers, industry partners, people with lived experience together to have meaningful conversations, the conversations that aren't often being had because they directly inform where we go next as the Lung Health Foundation. What should we be advocating for? What are the true needs of our health system partners, but most importantly, those that are living day to day with lung health issues? Next slide, thank you. Of course, none of this could be possible without sponsors. And our sponsors partner with us over the course of each year to really ensure that that integrated approach I talked to you about is benefiting people living with lung disease. So thank you very much to our sponsors. They've sponsored the whole Policy Forum series. We've already done one on COPD and an upcoming one on youth vaping. Next slide, please. So what are we going to do today? We're going to look at not only lung cancer screening, that's a place that the Lung Health Foundation does a lot of advocacy work in, but we want to kind of drill in and look at the diagnosis to treatment pathway and look at what are those current challenges, what could we and should we be doing better within Canada, across Canada. Next slide, please. And so what's that going to look like? We're going to talk about how lung cancer is diagnosed and treated in this country, and looking at Ontario as an example, what those roadblocks are, ways in which we might be able to, unblock the roadblocks, looking at advocacy solutions. So what could Lung Health Foundation do more of around raising awareness of some of these barriers and solutions? Next slide. So when we think about the cancer continuum of care, this is from Cancer Care Ontario, it's important to think about this continuum because we do a lot of work as Lung Health Foundation in the area of prevention and pre-diagnosis or screening. Today, we're going to kind of center in on that diagnosis to treatment piece. And I think that's just kind of important to think about the opportunity to do better and that part of the continuum of care. Next slide, please. So in terms of who our panelists are, I'm very happy to introduce you to our three panelists. So Dr. Rosalind Jurgens completed a fellowship in medical oncology with a focus on upper aerodigestive malignancies at Johns Hopkins Medical Institute. She completed her PhD in clinical investigation. She was on the faculty at Johns Hopkins until we recruited her up to Canada until she joined McMaster University in 2011. Dr. Jurgens' clinical expertise is in lung and esophageal cancer. She is also a patient advocate and serves as the Medical Advisory Committee Chair for Lung Cancer Canada. So welcome, Dr. Jurgens. Next slide. And Heather Hogan is one of our patient advocates. So Heather is a retired teacher and school administrator from Woodstock, New Brunswick. Having been diagnosed with stage 3A adenocarcinoma lung cancer in 2012, Heather knows firsthand the importance of access to potential life-saving treatments, early detection and research, advocacy and education, and has worked with other patients, caregivers, and stakeholders to create a community for those who have been affected by lung cancer. Heather is currently one of our patient partners here at Lung Health Foundation and a member of the Beatrice Hunter Cancer Research Institute Management Advisory Council and Research Committee, and a member of the Marathon of Hope Cancer Centers Network. So welcome, Heather. Next slide. And then Katie Hewland. So Katie is a marketing professional and advocate for lung health. She was diagnosed with stage 4 ALK-positive lung cancer at just 33 years old. Katie's journey has taken her from living in Toronto to now Victoria, BC, offering her unique insights into provincial cancer care experiences. She uses her experience to advocate for better lung health across Canada and is a lung health advocate with us here at the Lung Health Foundation. Now, when she's not working in her marketing career or advocating for lung health, you'll find her out hiking, exploring new areas or things to do, and being part of her community and spending time with friends and family. So welcome, Katie. And with that, next slide, please, Gloria. Actually, I think we can just turn off the slides, and I'm going to welcome the panel to all come on screen and unmute their mics. Before we really dig into the content, we wanted to just take a moment as a panel to share with those in attendance today of what each of you is hoping people get from today's discussion. And so I'm going to hand things over to Dr. Jurgens first to just sort of quickly sum up what you're hoping people walk away from.
Well, thank you so much, Jess. It's a pleasure to get to be here today. What I hope folks get out of this is their first vantage into what the journey of a lung cancer patient looks like, and the recognition that journey is going to look a bit different for almost every single person who decides to walk it or has the need to walk it, and to get to see the challenges that are being faced by these Canadians every single day.
Thank you. Katie, what about you?
Yeah, I would say it's quite similar. As a lung cancer patient, I noticed how important it was to get a speed to a proper diagnosis. So not just a diagnosis, but making sure it's precise to who you are and what cancer type you have. With lung cancer, it's not just lung cancer, it's lung cancers. And so the more precise we are means the more precise treatment and much better outcome. So I've been fortunate to be in that bucket, and that's not the standard, and that's not a common story in Canada. And I'm happy to discuss what that looks like and what that means for a better quality of life. So if people walk away knowing that there's a chance, there's hope, and we just need to get there for everyone, then that makes me happy.
Yeah. Thanks, Katie. I really like that. It's not lung cancer, it's lung cancers. That might be a theme that resonates by the time today's done. And Heather, what from your vantage point, what would you like people to walk away with today?
I would really like people to know that although there's still much to be done, the landscape has changed and improved so much over the last since I was diagnosed in 2012. And but to also know that there is hope, we're moving in the right direction. The fact that we are having these sessions in these forums now did not exist a number of years ago. So we are moving forward. We are lacking a lot of consistency across the country. And so we need to try and, I'd hope people would see that, yes, there are some inconsistencies and we need to work on that, but we need to work on that as a group, as a whole.
Thanks. Thank you for that, Heather. That's great. And so we're going to start digging in, and I'm going to ask Katie and Dr. Jurgens to go off camera, and we're going to give Heather this opportunity to tell some of her story. And Heather, I know you're speaking on behalf of your experience, but given so much of the work that you do in supporting others, kind of you're bringing many voices with you here today. So over to you in terms of what you would like to share.
Thank you. As Jess mentioned, I was diagnosed in 2012, stage 3 non-small cell adenocarcinoma, and mine was just an excuse me, an accidental finding. So I was one of the lucky ones. Just a CT scan, abdomen picked up on a little shadow that we watched, and boom, I was stage 3, and I was 52 at the time. So it came as a complete shock. I went through 2 lung surgeries, had 4 rounds of chemotherapy, platinum chemotherapy, and 25 radiation treatments. And I knew nothing. So the initial months of my diagnosis were actually a complete blur. And if my husband had not been there asking the questions and doing the research, I would still have absolutely no knowledge of what I had gone through, because it was, I wasn't in a good place. And the only people I knew that had lung cancer, and everybody told me, was that people died. So in my mind, that was what I saw my prognosis at. So I'm really happy to say that we've made a lot of great strides. I have no evidence of the disease, which is a very rare thing, and I don't take that for granted at all. So all of my experiences have led me down this advocacy path, and because of my experiences and feeling very lost out there, I felt that I needed to try and give back to the lung cancer community itself. So with all that said, I truly believe we've made great strides over the years. However, there's still a lot of work to be done. So advancements have been made in treatments like immunotherapies, targeted therapies, biomarker testing, and these advancements are enabling many lung cancer patients to live longer and have a good quality of life. We can't minimize these huge steps. However, with those steps, there's still more work to be done. And I would say beginning with general practitioners. When a patient presents with symptoms of lung cancer, a GP must consider the possibility of lung cancer regardless of age, sex, or smoking history of the patient. A low-dose CT scan, which is pretty much all we have right now, can catch lung cancer at the earliest stages. Screening programs, which are in place in many provinces, are great. However, the criteria for those being screened is narrow and also inconsistent across the provinces that have screening programs. The days following a lung cancer or cancer diagnosis can be overwhelming for patients and families. The pathway from diagnosis to treatment is different in each province and within provinces. Biomarker testing. What is it? Why do provinces test for why do some provinces test for lots of biomarkers or mutations and others with just a few? Who knows? Right now, it's all over the place. Nurse navigators, very inconsistent, but a necessary tool for lung cancer patients because they're fabulous people and can help direct the process. If you're fortunate enough to have an oncologist, like I know Dr. Juergens is, who takes time to explain everything to you, you're lucky because not every oncologist has the time or has the skills to be able to sit down and answer the questions you have. However, you need to know what questions to ask, which is another complication. Patient advocates have grown over the years, likely because we needed support and information we couldn't find anywhere. And I guess we can thank social media for providing us the forum to unite as lung cancer patients, particularly in this country. Knowledge is power, and many advocates work to fill voids in the system where information is missing. And as I said, you can't ask questions if you don't know where to start. Mutation? What's a mutation? What does that have to do with my cancer treatment? You mean there's other treatments besides chemo? What is it? Advocates are not oncologists, but our lived experience has provided us with information to share. Once again, this is done with the understanding that each province is very different. The inconsistencies in the pathway from diagnosis to treatment to post-treatment across the country and within provinces is significant and must be addressed, which is part of the reason we're all here today. Education and conversation are small pieces of a much larger puzzle. Lung cancer diagnosis, research, treatment need to be elevated to the same level as other cancers like breast, colon, and prostate. Unfortunately, for dollars for research, screening, treatment are competitive in the cancer world. However, the focus must remain on providing patients across our country with equal access to treatments and a consistent plan of action. Thank you.
As always, Heather, thank you so much. And Heather, you're going to be back with us as a panelist.
Yep.
And I have to give a special acknowledgement to our colleague, Marianne Bradley, who's also one of our patient advocates who wanted to be here on screen with us. She is here listening, but unfortunately came down, was a little bit ill. And so we're so grateful because we have such strong patient advocates that truly are sort of colleagues and family members and are able to support one another to have these conversations. So Heather, thanks so much. I've taken some notes in terms of some things that I think will come back up. And as Dr. Juergens comes up and starts to sort of what we've called kind of pull back the curtain on, okay, what's really happening? What are the things that we should be thinking about on the advocacy front and in health system change? I want to encourage everyone. We have both the chat open in Zoom, and hopefully by now people are pretty comfortable in Zoom. We also have the Q&A, so at the bottom of your screen, you can put in questions. We're actively looking at them. All of our panelists are looking at them, and that's going to help us when we open things up for more discussion. So I encourage you to tell your story, share comments. It doesn't always have to be a question. This is about what are people doing? What are you finding helpful? And connecting those that are in attendance just as much as it is connecting our panelists to the questions that you have. So with that, I'll hand things over to Dr. Juergens.
Oh, thank you so much, Jess. And I'm just going to scratch the surface today. I could probably talk for hours if you guys let me about this topic because it's quite near and dear to my heart. So I thought I would start just showing some disclosures, right? So I am a physician. I head our clinical trials unit at the cancer center that I work at in Hamilton, Ontario. So I'm interacting with different pharmaceutical partners all the time, conducting clinical trials, submitting research grants, providing advice, et cetera. So these are just some of the different companies, not some, all of the companies that I've interacted with in the last 2 years, just for disclosure that I do interact with our pharmaceutical partners. So you've already gotten a background on lung cancer, but for those of you who haven't seen some of the statistics, this updated set of statistics comes out as part of a report that I have been involved with writing for the last almost decade, that a group that I work with called Lung Cancer Canada brings out every year in alignment with Lung Cancer Awareness Month. So lung cancer is the most commonly diagnosed cancer. We have to recognize that both men and women, anyone with a pair of lungs, is at risk for lung cancer. We estimate that 30,000 people will be diagnosed with lung cancer each year. If you look at some of the other statistics, unfortunately, that leaves us in a space where over 20,000 Canadians will die from lung cancer each year. We heard already that lung cancer is quite handicapped with respect to the amount of funding. So we do a heck of a lot with a very small piece of the pie. Now we are seeing improvements here. Our 5-year survival rate is still low. It's only 22%, but we actually just jumped into the 20% range in contrast to what we see for some of the other cancers like prostate, breast, and colorectal. Lung cancer is a global disease. It is the #1 diagnosed cancer on the planet. So 11.6% of all new cancers, that's over 2 million people, will be diagnosed with lung cancer each year on the planet Earth. And if we look at what the impact is for mortality, 18.4% of all deaths are related to lung cancer. That's 1.8 million people who die on this planet every single year because of lung cancer. If we look at Canadian specific statistics, this is looking at how our patients, our people do with different cancers. So you can see here, these are some of the most common cancers that Canadians will be diagnosed with. So you'll see colon and rectum together, you'll see lung, you'll see female breast, and then prostate off to the right. And the one thing that should strike you is even the smallest of lung cancers, the lung cancers that are just a handful of millimeters in size, still only have a 5-year survival rate that sits at around 60%. We are not sitting at 90 to 95 to almost 100% like the other malignancies. And as soon as you get past 3 centimeters in size, if your tumor's over 3 centimeters, or if you've got evidence of lymph nodes, even if it hasn't spread outside the chest, the survival rates drop to 40 and down to 20% in stage 2 and stage 3. And as I mentioned, stage 4, we're still really trying to make progress. So lots of work to be done. So does anyone else feel like we can do better? I truly feel that we can do better. And how are we going to do better? And I wouldn't be doing justice to advocacy if I didn't move on to this next slide, which is we need to figure out how to identify people earlier before they have these more advanced cancers. And one thing I will point out on this previous slide is what do all the other cancers have in common that lung doesn't have? And that's active screening programs or minimally invasive ways to identify these malignancies early. So we've got fecal immunohistochemical tests and scopes for colon and rectum. We have mammograms now going down to the age of 40 in breast cancer. There's ability to get PSA tests and digital rectal exams for prostate cancer. And right now we don't have ready access to any screening in lung cancer consistently across the country. Why would we want to do screening? So my apologies, I am going to throw some data slides in here, but I think this is one of the most impactful slides that is in any of my slide decks. So the one thing to know about lung cancer screening is it not only impacts people's likelihood of surviving lung cancer, but it actually impacts their likelihood of just living in general. That is not true for any other screening program. No pap smear, no mammogram, no colonoscopy is going to actually have a person live longer. Lung cancer screening is different. Why is lung cancer screening different? Well, it's different because of 2 different things. One, we actually tie smoking cessation to lung cancer screening. So if someone is actively smoking, we provide them resources to try to help them be able to quit smoking. And we know people live longer just with that fact. If someone can quit smoking, they're going to likely live a longer life. The second thing is that the mechanism that we use for screening, which is a low-dose CT scan, actually can not only find lung cancers, but can find other things. A person might hear for the first time they have emphysema. A person might find out for the first time that they're developing calcifications on the arteries around their heart, and they might be referred to a cardiologist. There's lots of things that can be identified on a CT scan beyond lung cancer. But what I think is truly impactful is not just that we can have people live longer if they get CT screening. The second thing that's impactful is we make a huge difference in lung cancer specific survival. So this was a study, the Nelson study was done in the Netherlands, and they have a universal healthcare system in the Netherlands. And so what this trial did that I thought was absolutely fantastic is they took the people who decided to participate in the screening program, and half of the people received CT scans and half of the people received chest x-rays, and they looked to see, were lung cancers found? If a lung cancer was found, what stage was it? But what they did is then they laid that out in comparison to patients in their cancer registry. So these are the patients who are diagnosed through standard of care. They weren't diagnosed as part of a screening program. They just worked their way through the regular Netherlands system. And so they can actually then embed this nicely on top of just what we know about patients in the Netherlands with lung cancer. And what this graphic here on the right shows is that if you've had a CT screening diagnosed lung cancer, 50% of those are going to have stage 1 disease. If you have a chest x-ray, or if you just come into the system through the regular mechanisms, the outcomes don't look any different. A less than 10% chance you're going to have a stage 1A and a less than 10% chance you're going to have a stage 1B. We find very few stage 4 cancers. Only 10% are going to be found with stage 4 with screening, in contrast to nearly 50% of patients who are found through regular mechanisms or through chest x-rays will have stage 4 disease. So you can see this huge switch to having patients with earlier stages being identified if we implement CT screening. This is why it is so critical that we need to have screening. So where are we in Canada? You guys, this data came out at the World Congress on Lung Cancer that was held here in Toronto back in 2018. This was the confirmatory trial from the National Lung Screening Trial that came out in the New England Journal of Medicine back in 2011. Well, congratulations to British Columbia, and I see there's already mention of this in the chat. British Columbia has launched a province-wide CT screening program for smokers with lung cancer, and they do have a pilot program looking at screening never smokers as well. You can see that there are organized programs in other areas. Ontario has different pockets. It is not available provincially wide, but they're slowly but surely expanding regions. So there is availability in Toronto, in Ottawa, in Sudbury, as well as in the suburb north of Toronto. And we're hoping that other areas are going to be able to offer CT screening more broadly in Ontario. There's pilot programs in Quebec. There's pilot programs in Nova Scotia, and there's pilot programs in Alberta. But Manitoba, Saskatchewan, and the rest of the Atlantic Canada provinces have no screening at this time. So let's talk a little bit, since we don't have organized screening in any universal way in Canada, how patients actually come to our attention. So from my perspective, patients come to healthcare in one of 4 ways. So there's incidental, right? So for example, you are climbing up to clear out your eaves troughs before the spring rains hit, and you fall off your ladder and you end up going to the emergency room. And while they're there, they do a chest x-ray and they find a lung nodule. Or you're planning to get your hip replaced for your arthritis in your hip, and you get a chest x-ray and they find something. Those are incidental presentations where we accidentally find a lung cancer, just like you heard just a minute ago about how, we had a CT scan that was done of the belly and it caught a lung cancer at the very bottom. Now, sometimes patients come into their primary care physicians and they have symptoms, and that prompts a workup. Unfortunately, more and more often in this country, due to a severe lack of primary care physician access, people may present to a walk-in clinic, and a workup that's done through a walk-in may bring someone to light. And unfortunately, the ones that we hate the most are the ones that come into emergency and present into hospital because they've got such a large burden of symptoms that's the way that they come to attention. So many different ways that people can come to light. And it really takes a village. And I think that that's something that I want you to understand is everybody is responsible for thinking about lung cancer. So, what might be the role of a primary care provider? Often it is the first point of contact for patients with symptoms. And I'll tell you, those poor primary care physicians have got their jobs cut out for them because we have just come out of a pandemic. Here we are in a world in which now I feel like people have coughs and colds and pneumonias right, left, and center. And how do you think about lung cancer when we're all dealing with all these respiratory viruses that are running around? It's difficult. People have to be persistent to let people know if their symptoms don't resolve after a reasonable period of time. Now, that primary care provider actually is that person who does have the vantage on the entire patient, and they are helpful in being able to provide holistic care, making sure that we're thinking about not just the physical aspects of care, but the emotional aspects of care. The family health teams that are available in many of the provinces are extremely helpful in providing support to our patients. And they're integral for helping and talking about risks and benefits of things like screening as these programs are becoming more and more available. Now, there's respirologists, or if you're in Quebec, pulmonologists, as they like to be referred. These are specialists who have a background generally in internal medicine, who specialize in lung health. Many of them are not only clinical physicians, but perform procedures such as bronchoscopies or thoracenteses that can help diagnose a lung cancer. So lots of skills there. In Quebec, they actually often will treat the entire spectrum of patients with lung cancer or people with lung cancer. So they can make the diagnosis, and many of them are lung cancer treaters as well, similar to some of the models in Europe. And there's lots of different aspects of what a respirologist can do, and many lung cancer patients will encounter a respirologist as part of their world. There are thoracic surgeons. So we're very lucky in Canada in that the practice of lung surgery, due to work through one of my colleagues, Dr. Christian Finley, who's a thoracic surgeon, but is also a patient advocate and works for CPAC as well. He did a study looking at quality improvement and recognized that lung surgery should be performed by people who have specialized training and expertise in lung surgery. So now lung surgery is performed by thoracic specialists. So these are fellowship trained thoracic surgeons. They do manage often the earliest stages of lung cancer, so stage 1 and 2, that's their bread and butter. More and more now, they're playing a role in stage 3. There's been some really exciting new data about how many of these patients who might not have been offered surgery before may be candidates for surgery after something called neoadjuvant treatment with things like chemotherapy and immunotherapy. So we're seeing the surgeons taking back more of a role in stage 3 lung cancer now. They're often leading these things called diagnostic assessment programs that I'm going to talk about. And they can perform all sorts of procedures, from bronchoscopies to these things called endobronchial ultrasounds that help us stage our lung cancers, fluoroscopies, as well as the resections. So if we keep working down the path towards making that diagnosis, there's multiple different ways that this can be done, and each province has done it differently. This actually looks at what used to exist in Ontario. So there actually was a program that was set up over a decade ago, creating 14 independent regional diagnostic assessment programs. And these diagnostic assessment programs were tasked with trying to speed up the diagnostic phase of a lung cancer patient's journey. And I actually used to attend the meetings at Cancer Care Ontario, where we would sit down and put together metrics for what we thought was reasonable from a person presenting with symptoms that might represent lung cancer to having a package of information that would allow the most appropriate person to treat that lung cancer. Unfortunately, after the pandemic, the provincial funding for these diagnostic assessment programs was rolled back. So some centers have continued to support them. So we're really lucky in Hamilton, where I work, that we've kept our diagnostic assessment program running without any provincial funding. But other places have not had the ability to do so. So the efforts that were put into place to speed these diagnoses and to have a one-stop shop for walk-ins and primary care providers and ERs to send these questions about diagnoses have disappeared. And this is a sadness for me, because I think that we've seen a backslide in how quickly we've been able to make patients get through that diagnostic journey. And there was such wonderful work that was done. I have to give a shout out to my colleagues in Ottawa. They felt like this was such an important part of their world. They actually created something called the Diagnostic Day. And they worked with their entire healthcare system, their radiologists, their healthcare administrators, to sort out how could they pull the levers that they needed to pull to make it such that patients could get their CT scan, their PET scan, their MRI, all ideally in one day to, one, speed the process, two, make it more convenient for people who are going through this journey, and three, hopefully get that person to the right subspecialist who was going to lead the team in managing that person's cancer, assuming cancer was identified. We need more of that, not less of that. And so one thing I want you to take away is I think we need to advocate for more organized programs that allow it to be an easy thing for a family physician, a walk-in physician, an ER physician to get suspected lung cancer to that right team. Now, if we look at how are we doing, it's not like we're doing great in Ontario. Ontario's diagnosis to treatment interval for lung cancer is longer than most jurisdictions. It was the longest of 10 jurisdictions in Canada, and you add in Europe and Australia, and we're woefully behind. So we really do need to do better. It's not like we were doing amazing, and so disbanding the lung diagnostic assessment programs was because we were making these diagnoses so quick and they didn't need the funding anymore. We still have a heck of a lot more room to move on this. So if you look, we don't even have targets in the province of Ontario. I don't know about the other provinces as to whether or not their provincial bodies have targets. But if we look at what's being tracked by things like Ontario Health, Cancer Care Ontario, there's not even a guidance for how long it should take a lung cancer to be diagnosed. If you look, I did a survey of the different academic hospitals across the province of Ontario, and most of them are seeing from a needle being put into a patient. So when that first diagnostic test is being done to get that tissue diagnosis, most places are in the realm of 3 to 4 weeks for the entire package of information to come back. In some centers like my own, that diagnostic path can take somewhere from 6 to 8 weeks. So we're double the provincial average. And that's not just us, that's our whole region, right? Because we're doing the testing for not only Hamilton, we're doing it for Niagara, Burlington, Brantford, Kitchener, Waterloo, et cetera. So it's this whole neck of the woods that's being affected by not having a benchmark that we have to follow. So, honestly, due to resource constraints, diagnostic journeys have really gone down. We're seeing longer wait times. We're seeing longer wait times just to get a CT scan, not to mention a low-dose CT scan for screening. We're seeing longer waits to get biopsies. We really need to find a way to do better, and centers aren't going to be motivated to do better unless their provincial regulators come back and say, this is a priority. You need to move the needle, and this is your benchmark. With no benchmark to hold to, we're never going to see progress. And unfortunately, lung cancer just never makes its way up the chain of things that are seen as a priority. There's priorities for how quickly we have to turn around pathology for colon cancer after resection. There's priorities for how quickly a woman with a suspected breast cancer has to make it their appointment to their first treatment provider. We have nothing like that for lung cancer, and we really need to push that. We need metrics that centers have to hold to be able to get those patients through that journey. So let's look a little bit here at what that lung cancer journey looks like. I've talked a little bit about screening. We have all sorts of imaging tests that need to be done, and you can't just get a one-stop shop. I need things like an MRI for brain, ideally. Lung cancers are one of the most common cancers to go to brain. I need a CT scan of the chest and the abdomen because lung cancers can spread to places like livers, adrenals, etc. I need something to look at bones. We can look at bones through a couple of different imaging modalities, PET scans or bone scans. In the province of Ontario, we use PET scans for anybody who doesn't look to have stage 4 disease on their imaging CTs. If someone does have stage 4 disease, we generally do bone scans. So I have to order 3 different tests potentially for these folks to be able to actually get a full just imaging workup. And then I actually also have to have a biopsy arranged. We've talked a little bit about how it's not just lung cancer, it's lung cancers. When I first started in medicine a couple of decades ago now, everything I needed to know about lung cancer, a pathologist could tell you with looking through a microscope with their eyes. It was basically the cells were small, the cells were not small, and that was all I needed to know to make a recommendation for a patient for treatment. Now I need to know, is it small? Is it non-small? Is it adenocarcinoma? Is it not an adenocarcinoma, like a squamous cell carcinoma, et cetera? And then I need molecular testing. And there's literally a dozen tests that I need done that help personalize the care of the patient that I'm treating. And it used to be it only mattered in stage 4. Now it matters across the entire spectrum. There are implications potentially for stage 1, 2, 3, and 4 to know that full molecular profile. And that molecular profile takes an additional 2 to 3 weeks on top of just that diagnostic small versus non-small piece of information that I used to need back in the day. The reason that I'm jumping up and down about how I think we need benchmarks and I think we need someone to say, lung cancer patients deserve to have themselves through that entire diagnostic journey in, say, 4 weeks, is because lung cancer patients are some of our highest risk patients to unfortunately start falling down the ladder of something called performance status. So performance status is a very dull tool that we use in oncology to give us a sense of how well is a patient functioning. So someone who is an ECOG 0 is someone who has no functional limitations, okay? Someone who is an ECOG 1 has some limitations. They have limitations with physically strenuous activities, but they're otherwise able to perform light work, etc. Performance status 2 is where you start to teeter on whether or not more aggressive treatment options are even available. These are patients who are, ambulatory. They can do all of their own self-care, but they're really not doing a heck of a lot of work, but they have to be up and out of bed 50% of the day. And you're like, gosh, Roz, that's not a very high bar. Well, the average lung cancer patient is 71. The average lung cancer patient has at least 3 different medical issues on top of their lung cancer. We've got to remember that people bring baggage that they've accumulated before their diagnosis of lung cancer to the table. So they may not have been, that mobile before their diagnosis of lung cancer, and then the lung cancer starts sapping their strength. And then all of a sudden, someone who is able to do all the bits and bobs around their home finds that they need help. And then you start to get into performance status 3. They can barely do their own self-care. They're washing their face, they're brushing their teeth, they're getting themselves dressed, and that's the best that they can pull together in a day. Those patients are very difficult for us to treat. Someone who's completely disabled, almost impossible for me to treat. And so we get down this slippery slope where it doesn't take long for a person who's diagnosed with lung cancer, where this lung cancer is acting like a bad dictator and it's stealing their nutrition and it's stealing all their building blocks and it's stealing all their energy. It makes these people feel like they're running a 5K every single day, even if they've never moved off their couch. You can see how that would exhaust you when you're doing that for weeks on end. And you all of a sudden start going down the ladder. This is just a somber moment of looking at what lung cancer has been like over the years, right? When lung cancer was first even recognized, the median survival of this disease was only 4 months. When we brought things like chemotherapy to bear, and we had a couple of different types of chemotherapy we could use, we doubled the survival to 8 months with adding chemotherapy. But now that it's not just lung cancer, it's lung cancers, we actually are seeing huge improvements. And we're talking now, even with stage 4 disease, with certain diagnoses like ALK that you're going to hear about, where the median survival can actually now approach up to a decade with stage 4 disease that used to have a survival that was less than a year. So you really want to know if you have ALK so I can get you the right treatment. You really want to know if you have EGFR, for example. And so that brings us to treatment. And, treatment's a complex thing. I spend a lot of time talking to patients about their diagnostics and how that implicates what treatments I'm going to offer them. And it's really important when it comes to all the therapies. So I'm going to spend the last little bit of my time talking about treatment. And I'm going to talk a little bit about the haves and the have-nots. So this is just a slide that I use when I talk about both wonderful things and less wonderful things. So let's talk about the wonderful things that I see on this slide. Well, one of the wonderful things I see on this slide is the fact that immunotherapy exists. I had the good fortune of being part of the very first in human clinical trials of the first PD-1 inhibitor, a drug called nivolumab, that came to patients in clinical trials back in 2009. And now you'll see there's a whole plethora of different immune-based treatments that are focused on unleashing a person's own immune system to help fight their cancer on their behalf. And this is just some of the different places in lung cancer where we've had drugs that are approved. And you'll see stage 3 lung cancer on the left, and you see frontline metastatic disease in combination, for example, with chemotherapy in a few different places. And you'll see if we work our way all the way to the right now, truly bringing it to the earliest stages of lung cancer. So you see treatments where we're giving it in the post-surgical setting, and now we're giving it in the preoperative setting or the pre and post-operative setting. What's not so great on this slide? Well, I show you on the top of the slide all the little US flags and the EU markers. That's when these approvals come to places like the United States. That's when approvals come to places like Europe. And the Canadian flags on the bottom are when we get access in Canada. And you might note that almost always the Canadian approvals are coming months, if not a year later than some of these other jurisdictions' approvals. So Canadian patients have to wait. And there's literally nothing that we can do because we're at the mercy of the pharmaceutical companies actually bringing this package to our regulator, like our regulator, Health Canada. An individual can't bring a file to Health Canada, and there is only so much bandwidth for pharmaceutical companies. So they're going to pick their easiest places to get access first. They're going to go to the Food and Drug Administration, where an FDA approval equates to Medicare approval all in one fell swoop. Canada's a much longer process to get access, not only to Health Canada, but then actually to patients. And so we're seeing actually a deterioration in the time to which we see drugs brought to our regulator, Health Canada. So here's a graphic that shows this. This is a graphic that came out of the Faces of Lung Cancer report that we brought this last Lung Cancer Awareness Month. This is just looking at some of the recent indications for use of immunotherapy that are available in Canada. So the average amount of time from FDA approval date to when there's provincial funding. So there's multiple steps here. So this isn't FDA versus Health Canada. This is the entire spectrum. So this is US Medicare patients can access drug to Canadian patients can access drug. That's what the time frame is here. The average difference, 752 days. 2 years between when a Medicare patient in the US can access to when a patient across the different provinces can access. Now, you may see here, this doesn't happen at the same time in all the different provinces. PEI often lags quite a bit behind the other provinces. There's all sorts of things that factor into different rationales as to why different provinces will pick things up. But Canada is not, a fondue pot, right? We're not all mixed together. We're a quilt. And depending on which province you're in, you're going to have different access at different times. So let's talk a little bit more about targeted therapies. And you've heard a little bit about ALK. There's actually now many, many different what we call driver mutations that we look for in lung cancer. And this is just a small snippet of that. So this gives you a sense of how many people with lung cancer, specifically mostly adenocarcinomas, although some of them you will find in our squamous cell carcinomas, how many patients might have these different drivers. The most common driver is something called KRAS. We learned about KRAS back in 1987. It wasn't until more recently that we have discovered that there's things that we can do for KRAS mutant lung cancers, but only a small subgroup of them. Ones would have something called KRAS G12C. That's about half of the patients with lung cancer. We learned about EGFR back in 2004, and that's about 15% of our patients with adenocarcinomas of the lung. And then you'll see the rest of the list. ALK is about 5%. There's something called MET skipping that's around 3%. RET is 2%, ROS1 is 2%, BRAF is about 1 to 2%, and then NTRK is a little less than 1%. And you can see on the right all the different drugs that are Health Canada approved. The problem is Health Canada approval does not necessarily equate to provincial funding. So why do you want to know if you have a mutation? Well, the thing is mutations don't necessarily have a prognosis associated with them. They're predictive biomarkers. So if I don't know you have it and then I don't match you to the right treatment, it's not going to help you. So just knowing you have ALK doesn't help. You have to know you have ALK, and then you actually have to get access to the drug that works with ALK, or you have to know you have EGFR and then get access to the drug that works for EGFR. And this was an elegant study that was done by a group out of the US. And it looked at patients who did not have a mutation, and then patients who had a mutation but never got access to treatment. And those are the two blue lines. And note the two blue lines sit right on top of each other. Just knowing you have a mutation doesn't help you. But if you find you have a mutation and you pair that person with the right treatment, you can dramatically improve that person's survival. So it's a really important thing to A, know if you have a mutation, and B, get access to treatment. So let's talk about that next part. Access to treatment. So let's start with some good news. So these are the agents that we in general can access in Canada. So for EGFR, we've actually got access for inhibitors that span the spectrum from stage 2 all the way to stage 4. So this is really great news for us, for folks who have EGFR mutations. There is a subtype of EGFR that doesn't do as well. They're uncommon mutations. There's a specific uncommon mutation called an exon 20 insertion. We're actually developing separate drugs for that particular subgroup of folks, and there's been some real stressors around exon 20 insertions and drug approvals in that space. So right now, people who have exon 20 insertions, all they get is chemotherapy. ALK, we've got multiple inhibitors for ALK. Now, one thing that's different in Canada that is different from all the European jurisdictions, the US, is Canada, they have decided to fund one ALK inhibitor unless you've got a private drug plan. So your oncologist has to pick what they hope is the best ALK inhibitor for you, because you're likely not going to get a second one. That's just the way that the funding has come out. We have tried to buck this. We have gone to the different bodies that fund the different agents about explaining why it's important to keep multiple options open for ALK inhibitors, but unfortunately, that is not yet the reality for the majority of our ALK positive patients. We've got access to a frontline ROS1 inhibitor. We've got access to a frontline RET inhibitor. We've got access to TRK inhibitors. Unfortunately, because it was not randomized data, we have access to TRK inhibitors after failure of everything else. You have to go through every chemotherapy option we have before the provinces will fund a TRK inhibitor. I find this a bit ridiculous because the response rate, the chances I can get the cancer to shrink with a TRK inhibitor versus chemotherapy is 4 times. So 4 times the chance of me shrinking. The durability is 3 times, but I have to try less effective therapies first before I can get a hold of a more effective therapy. So this is what I was talking about. Welcome to the land of private drug plans. Now, all of a sudden, we've become a world of have and have nots, because I'll tell you, most of my patients don't have private drug plans. So then we're stuck where we're only able to access the things that have provincial funding. So here's just a few highlights. I was talking about those exon 20 insertions, those very specific type of EGFR mutation. We actually got this drug to be recommended for funding through a group called the CADITH group. They couldn't agree on a price. So we've now got some randomized data, and I'm hopeful that we'll be able to do this, but this just means longer that patients with exon 20 have to wait before they can get a provincially funded drug. BRAF. This one kills me. This one absolutely kills me. Sorry, I'm going to say that twice. BRAF mutations are found in multiple cancers. We know about them in melanoma. We know about them in lung cancer. They're also found in a certain type of thyroid cancer. The chances that I can get, whether it's a melanoma or a lung cancer, to shrink with a BRAF combination is exactly the same. The duration of time that shrinkage lasts, whether you've got a melanoma or a lung cancer, is exactly the same. The problem is it's a small subgroup of lung cancer where it's half of melanoma. So they've done larger randomized trials in melanoma. They didn't do larger randomized trials in lung cancer. We got it passed and we got it to provincial negotiation for funding. But for lung cancer patients, the regulators said that they wanted over an 80% price reduction. So a lung cancer patient, the province is only willing to pay 80% of what a melanoma patient would have had a drug paid for. I'm sure I'm glossing over this, not in quite the right terms. All I know is it came down to the fact that the pharmaceutical company said, we can't take that low of a price for our compounds, so we're not going to be able to offer these treatments to lung cancer patients with BRAF unless you've got a private drug plan. So melanoma patients get it, lung cancer patients can't have it unless you've got a private drug plan. MET skipping. Here's going to be some fun, mind-blowing stuff and talking about the quilt that is Canada. So there are two different drugs that work for MET skipping, a drug called tepotinib and a drug called capmatinib. Tepotinib went, Health Canada approved, got recommended, or did not get recommended for funding, and we've been trying to battle this back and forth. But somehow Quebec looks at the data and says, we think this is great, and we think this is something that Quebec patients should have. So these drugs are actually available in Quebec, not available in the rest of the country. The manufacturers of the BRAF drugs are also a manufacturer of this agent, the capmatinib. They were so tired, I think, after battling about BRAF, they also didn't have randomized data with MET skipping. They haven't even bothered to try to look for funding. They said, we're not going to just donkey and try to keep going after the same thing if they're not going to give us funding. So they didn't even bother attempting a file at getting funding for that agent here in Canada. So now, unless you live in the province of Quebec, if you've got a MET skipping mutation, you're out of luck unless you've got a private drug plan. Same thing just happened with KRAS. So there is the first-in-class KRAS inhibitors. There was a randomized trial looking at this oral agent versus a chemotherapeutic that was an IV agent. There was a small improvement in progression-free survival, a very small improvement in overall survival, but oral agent versus IV agent, that was not seen to be a big enough benefit for a recommendation for funding. So we just found out this week. We argued back that they misinterpreted the file, and we felt that they really needed to weigh more heavily that this oral agent, which is a patient-centered thing, should, even if it's not dramatically better, even if it's the same as an IV drug that gives patients freedom, they should be able to have that choice. Well, again, unless you're in Quebec, you're not going to get that choice because Quebec said, this is good for Quebec patients. Quebec patients should have access. That's not going to be the case for anybody else in any of the other provinces. So here's the gaps. And I'm just going to show you this. This is that same graphic from that Faces of Lung Cancer report. This is showing some of the different trials. The ones in sort of orange are ones that did not have randomized data. The ones in green are the ones that do have randomized data. And you'll see dramatic differences in how quickly we were able to get access. I'm not going to say it was quick. It was still slow, but it was half the time that it would take something that did not have randomized data to get provincial funding. We are sitting at 902 days. So 2.5 years from when the FDA approved and gave their Medicare patients access to when Canadian patients would get provincial access. Now, the other thing I didn't even talk about is how we deal with orals versus IV. IV is consistent across the provinces. IV is covered by your provincial programs. So if it's an IV treatment, no matter what province you're in, as long as your province has decided to fund, you get access to the drugs. Oral agents are hodgepodge. So if you're out west, oral agents and IV agents are the same. So if you're in BC, you're in Manitoba, you're in Alberta, If it's an oral anti-cancer agent, it's an IV anti-cancer agent, it's provincially covered no matter what your age. Come to Ontario. If you're under 25, it's covered. If you're over 65, it's covered. But if you're between 25 and 65, you have to have a private drug plan because there is no coverage except for applying for something called Trillium, where it's a needs-based program. So you have to apply to Trillium, submit your taxes. Like, can you imagine being a stage 4 lung cancer patient being told, hey, I've got an ALK inhibitor for you. Can I see your last 3 years of taxes? Can you please submit those to get access to this Trillium program? It's just incredible. One of my colleagues out of Ottawa published, I think, a really powerful piece on what the impact of these delays in funding is. And this is just showing you the number of Canadian life years lost while we've waited for therapies. These aren't even the fancy things. The bottom is just chemotherapies we had to wait for. The top are some of the fancier things. Thousands upon thousands of Canadian life years lost while we've been waiting for drugs. We've got access challenges. We've got equity challenges. I don't know how many of you watched the very popular Netflix series, The Squid Game. The Squid Game was basically a series of games, and somebody died at the end of each challenge. Do you know how many drugs of lung cancer have died trying to navigate the game of healthcare access in Canada? Too many, too many. It shouldn't be this complicated. Lung cancer patients shouldn't have to wait this long. We need to do better. So I'm going to stop my talk here. We're gonna move on and hear a little bit more from one of our other patients and advocates. But this is just not right. There are so many struggles. We need more advocates. We need physician advocates. We need patient advocates. We need caregiver advocates. We just need people who care about people with lung cancer. And I'll tell you, if you look around yourself as you sit in a restaurant, there is someone likely there who's been impacted by lung cancer. So please, please join us.
Thank you, Dr. Juergens. It's been a lot of people are sharing their stories, and what you're saying is very much resonating. So I'm going to hand things over to Katie to talk a little bit about her experience and sort of what resonated. And then we're going to open things up for questions and additional comments. So this is a chance to kind of get into that chat or Q&A section and put your other thoughts down. And so we will open things up shortly and talk about what are we going to do and what are we going to do together to try and address some of what is coming up in terms of opportunities here. So Katie, over to you.
Hi, and thank you so much, Dr. Juergens. That was a complete informative presentation, and I could definitely see myself in a lot of these. So I'll talk a little bit about my experience, and always happy to connect with others as well. So I was diagnosed at the age of 33 with stage 4 ALK positive lung cancer. The only symptom I had at the time was a cough, some tiredness, but the cough progressively got worse and worse. My GP at the time had put me through multiple different tests or puffers. I was on steroids. We tried that for about 3 months. I went to specialists, and at the end, it was an X-ray, which has been talked about as a screening tool, that detected a mass in my lung. Unfortunately, my GP still didn't think it would be anything related to cancer and thought it might be something else. With further testing, blood work, and then an ask to go to an emergency department. I spent the day in emergency to find out that it was cancer. And over the course of a few days, we understood that it had spread throughout my body. What I would say, although that is not the story people want to hear, I think what is important is to think about how do we detect cancer in people that are non-smokers as well, and who are under an age of, let's say, 40 or even 50. So I typically did not hit many of the markers that would be seen. And I do think that GPs need to be more informed and aware of that cancer can hit at any age. Once I got my diagnosis, however, the story really changed, and I think I was a success story in that nature. Within diagnosis, I was able to access at least radiation initially, more for a palliative standpoint. The tumor on my lung was really pushing on my airways, and they were worried that I wouldn't be able to continue almost breathing within a month's time. And so the action, until we knew more about my lung cancer, was to do radiation. And so fortunately, I was put into radiation within 2 weeks. During that time is when biomarker testing results came back, and I found out I had ALK positive cancer. And so, as Dr. Juergens has mentioned, this is so key to understanding your treatment path and the quality of life that you can get as a result. And so from there, I was put on a targeted therapy, which is an oral therapy. So I can take it from my home. In BC, now that I've moved from Ontario, it actually delivers to my home. So I don't need to go and take time to go to a pharmacy or a hospital to take this. And I started on this about 5 to 6 weeks after my initial diagnosis. Within 2 to 3 weeks, I had immense success. The cancer had reduced across my body, and over the next year and a half, I continued to have a reduction. And still to this day, it's almost being managed as a chronic disease. What I would have to say is that speed to treatment was so critical, not only to help alleviate the bad symptoms I was having, not only to reduce the cancer that was existing in my body, but also just the quality of life. I actually returned to work within 3 weeks, which is quite shocking to hear that I only initially was told I would have a few months to live. So the quality of my life remained about the same. It took some time to figure that out. And so not only is it important to have these standards of care, so when you are diagnosed, that you are understanding your mutations, that everyone has access to this test. It's also important to get those therapies. And so making sure that the system is enabling these access to therapies, not in 2 years once it is approved, but sooner. And making sure that we continue to have access to drugs that not only provide longevity, but a high quality of life. And then lastly, what I will point out as well is I was diagnosed in Ontario. I had the fortunate circumstance to be treated at Princess Margaret Hospital, and my oncologist at the time was an expert in various mutations, but ALK positive cancer. And I really do feel that her knowledge helped to accelerate my therapy and my success. But I would have to say, as mentioned in the presentation, what I did next was, we have a great therapy for you. You do not need to do chemo. You do not need to continue radiation. You can continue to travel the world and live your life, but it costs you $11,000 a month. And to navigate the world in Ontario at the time through my private health insurance, do I have health insurance? It took almost 2 weeks just to go through the paperwork and the calling. At this point, stage 4, I really needed to move quickly. And so trying to access from a financial standpoint is a very different thing than just having access to a drug in Canada. However, when I moved to BC, even though I did have coverage, thankfully, through my work plan, which it doesn't mean everyone with a private insurance will have access to it, let alone not everyone has that access. So once again, I'm in a fortunate circumstance. When I moved to BC, as mentioned, under the cancer care program here, I am able to have it covered, just like the IV or an in-hospital, like chemo, radiation. My take-home therapy, the one that I can take by oral, is covered and is actually sent to my door, and I don't need to worry about it. I don't need to go through insurance. And so I would love for this model to be expanded across in central and eastern Canada as well. This is a model that takes place in BC as well as some other Western provinces. And so across the spectrum, as a patient, not only are you trying to get diagnosed properly, it is incredibly important for you to have a good working relationship with your oncologist, and for them to provide you on the right path to get treatment quickly and effectively, but also making sure that you're not stuck with an exorbitant cost that is not accessible at the end of the day. And so I'm always happy to talk about my experience in Ontario and BC, as well as diagnosis to treatment pathways.
Thank you, Katie. Thanks, Heather. Roslyn, you're welcome to come back on as well. one of the things, just in terms of the slides that we had sort of brought together what potential areas we might want to advocate more in, and each of you has sort of highlighted some similar, of course. So I wonder first if maybe what we do is just ask you guys, do you have questions or kind of comments or reflections for one another now, having sort of heard what each other's said, or things that you were reminded of in hearing the stories from across the presentations?
You know, one thing I took a chance and scrolled through the chat to see what all had come in. You know, there's been a lot of questions around testing. And this is a very tricky beast and is also very different province to province, where some provinces are extremely strict about funding for retesting, whereas other provinces are not. I'll probably get in trouble, but like Ontario's, they're a little more loosey-goosey with respect to doing repeat testing on patients. Whereas, again, from what I've heard out west, it's actually been a much bigger struggle to even get testing into the earlier stages, which we've needed for some of our new preoperative treatments. That's what the delays have been, and getting access to some of the preoperative treatments that have big overall survival benefits out west have been that they had to figure out the testing piece first, because you have to have testing before you can recommend some of these different treatments. And so they had to figure out how to be able to expand their programs to allow that whole group of people who weren't getting testing before to get testing, to be able to facilitate that. You know, I do think that this is a place worth pushing on. Technologies change. That's a whole different slide deck that I don't have in here, but I have patients who, you know, are of Heather's era, right? I could think right now of a patient of mine who was diagnosed in 2012. 2012 was a weird year in Canada for lung cancer patients, in that the only testing we had was for that EGFR mutation. And for a very long time, that test was actually funded by a pharmaceutical company. And after, I'm not sure how many years, but many, many years of funding every single Canadian patient with stage 4 disease to have that test done, the company's like, you got to figure out how to pick it up as a country. And we just lost access to do testing for EGFR in Canada. And so eventually the different provinces started to figure it out. And I remember very clearly, this is just as I had moved to the country coming from the US, and I'm like, okay, I had access to all this stuff, and now I can't even get EGFR. Like, I was paying for EGFR out of research dollars on patients because I thought it was the right thing to do in that gap. But I had a patient who got the testing done by the test we had available in 2012. Once we got it back, he was negative. We fast forward, and there's some more tests that became available. So we reran his tests. And lo and behold, there was one small gap in the testing we were doing back in the time. And he did have an EGFR mutation. It just wasn't one of the EGFR mutations that our test could capture at the time. And so you may think, I don't have an EGFR mutation. But if you were Heather and your test was done in 2012, the tests are actually better now. And the test that you had back in 2012 may not be right. So when I do teaching of my colleagues across the country, the first thing I tell them when your patient is failing their current strategy is go back and look at their testing, go back and look and see if it's accurate, like modern testing. And if it's not, try to figure out a way to get the testing redone, because you might be missing an opportunity for a patient. And these aren't small opportunities. These are huge opportunities, right? You know, if you found out that you had a mutation that had a tablet that could extend your life by years of time, dang straight, you want to know it exists, right? So I think it's really important for us to figure out how to make these things accessible. The other thing we haven't even touched on, and I'm hesitant to do so, but I'll do it anyway, right, is all the testing we've talked about has been the difficult testing to get, right? This is testing that Heather and Katie have experienced where I actually have to take a needle and stick it into their body and actually pull cancer cells out and have someone process them and look at them under a microscope. There's now technologies where we can actually profile the DNA and RNA that's floating around in people's bloodstreams and get similar testing. You can't make a diagnosis this way, right? So I can't tell you that this is a lung cancer versus a pancreas cancer versus a breast cancer through this technology. But if I actually have that information, I can then reprofile somebody just on their blood. And so, the grant that I got through the Lung Health Foundation was actually trying to help speed that diagnostic journey by adding this blood testing into the testing protocols so that my patients who live rurally, who are less financially fit, we have patients in our region who miss their PET scans or miss their biopsies because they can't take another day off of work, which I know sounds crazy, but that is the reality in 2024, where if you don't get paid, you either choose to pay your rent, pay your food bill, pay your gas bill. Like that's the world in which people are living right now. And so people are forced to make really difficult decisions when you have to come to what could be 10 appointments in your diagnostic journey, right? Like that's hard. So
Yeah. No, I think those are all fair points. I'm going to have Gloria share slides, so stay up, guys, because I want to be able to condense so much of what we've covered into the potential. Yeah, slide 57, Gloria, thank you. Next slide. Into potential areas for advocacy. And while we're doing that, there's a link. I'll ask, it's up there right now. So if you look in the chat, one of the opportunities for action that we have for today and ongoing is an opportunity to follow the link, and you can type in your postal code, and we have a letter that you can tailor, and it will send to your local media outlets based on your postal code. And the letter essentially is just saying, this is an issue. We need to be talking more about lung cancer. And the gaps and the importance of advocacy. So we thought if there's one step each of us as individuals could take is sort of amplifying that message. And we're here to support. Hopefully some media outlets do kind of pick it up and start to raise that conversations. It's one small way in which it's a small tool in our advocacy toolkit, if you will, but it's a good starting point. So just for people to think about that as we talk about some of the places where we may go in terms of advocacy. So certainly we're going to continue doing work in all of our advocates, Dr. Jurgens included, around screening programs. We talked a lot about benchmarks and standards for diagnosis because they're lacking in Canada. Certainly we heard the Ontario example. This is an area that likely makes a lot of sense to put more focus on in terms of let's establish some benchmarks and standards here. Because from there, then we've got the data we need to truly understand, okay, what is happening? What do we define as quality care? Next slide. So overall, what we're hearing and thinking about at Lung Health Foundation is it's probably needing to define some kind of strategy or pathway for that diagnostic treatment journey, right? So not just the benchmarks, not just the standards, but kind of mapping it to, okay, so this is the journey that we really should be offering in an equitable way as much as we can across Canada. So it shouldn't be dependent just on your health system in each of your different jurisdictions, for all the reasons that you guys have raised. And I really appreciate Dr. Jurgens bringing in the data too, because it is data driven. We have the evidence to suggest that it's just not okay, the level of discrepancy that we have and the level of variation. And that's a lot of what the comments have been that have been shared by people on here. So what might that look like? We have to talk about whether or not we've got the resources allocated to address the diagnostic to treatment journey, because there's lots of health human resources we can think about. The accessibility of the certain tests, technologies, Roslyn, as you started to talk about, making sure that those benchmarks are configured, but then also that we report on it from a health system performance perspective. Next slide. And then also, how do we support people with lung cancer and their caregivers in navigating the diagnostic to treatment process? So you each have touched on that in your own way. And there are some good examples of how that's happening within cancer systems, where you've got a nurse navigator. There's groups like ours that have patient programs and programs for caregivers. And, we try to work as best we can with the other lung health organizations. But we really shouldn't be doing that as a patchwork quilt, right? Like, how do we come together and say, how do we support people that are going on this journey, recognizing the journey is going to be different for everyone, but we have to be able to better empower people. And Heather, you spoke to that, right? Whether you're a healthcare professional, many of whom are on the line today, how can you better your skills around having the conversations and being aware of what to be asking and what to be looking for, to know where your patient is at that particular time and what support they might need? But then also, how do we empower the caregivers and people that have just been diagnosed or are going through that pathway to also sort of know, okay, what questions to ask when and what's reasonable to expect? So I think that's another key theme that emerged. Next slide. I put this one in here for Dr. Jurgens in terms of, well, innovative models, right? So it might not be the lung cancer diagnostic assessment program as it previously existed, but if you think about that map of Canada, and there is good work happening in those provinces that don't yet have a full screening program, business cases and such, but there's a big gap between having full coverage when you're a province that doesn't even have a program yet. So we need to be looking at how we scale and spread things that will work in the absence of having something that would be the ideal. Next slide. And so we've talked a little bit about this, Dr. Jurgens, around achieving greater efficiency for biopsies, that clear diagnosis to be able to initiate effective therapy. A pathway would be able to help hopefully address some of those discrepancies across jurisdictions, thinking about biomarker testing, but that's just one example. And a big piece that's come up, and I think a lot of people are a little bit in shock, quite rightly, Dr. Jurgens, when you went through, like, here's the reality of what that process looks like in terms of approval of drugs, but also the coverage and access to those treatment options. And Katie, I really appreciate your point around that's one part of it, but then can the person actually afford it, regardless of whether or not it's available? And so as a lung health foundation that's here as a patient advocacy organization, I think this is an area that really makes a lot of sense for us to dig into a little bit more. So we can stop sharing slides for now. And how does that resonate? Do you think that's reflective of your experience, reflective of the conversation we've had? I invite others to add their comments to the chat as to whether or not those are the kind of, is that the right direction for us to be thinking about as we think about what we should be advocating for in this space? Heather, Katie, thoughts?
Yeah, I would, yes, I think you're right on. And I think we all, in our own way, brought up a lot of those points. And I can, when I was diagnosed, nobody said anything about a mutation. I have no idea, not a clue. Wouldn't have known anything about mutations or even to ask about it. So I'm sure maybe there's something in a pathology report somewhere where my tumor was in a place that was not easily accessible to a biopsy. So maybe in my own way, not knowing what I didn't know was kind of beneficial, because we just steamed forward ahead, and I had surgery, which was not protocol, but I didn't have a PET scan. So I was just kind of lucky in a lot of ways that it's worked out as it is. So, but the longer I'm involved with all of this, I think that patients are doing much better, becoming much more informed, and they are starting to say, no, I deserve to have information and I deserve to be able to ask questions and have them answered. So there's that component of it. But I think also the realization that how different things are across the country, whether it's drug approvals or whether it's treatments, how those are done. Your drug that Katie takes that is delivered to her home versus somebody going into the hospital and having an immunotherapy done through an IV. Like, until you're into this, you really don't know. And I think it's really incumbent on patients and physicians and groups like Lung Health to work together to push this forward, because everybody's in each individual province is working in a silo. And we waste an incredible amount of time because we have those provincial boundaries. And I understand about the fiscal part of it, but we really need to work more as a team on this. And I would, that's something that, and I do know that there are some groups that work, pan-Canadian groups that work together, and that's awesome. And so we have to keep working at this, but we have to keep pounding it hard. And sometimes people get tired. They just get tired, and it's why you're fighting for this all of the time, and it's important, but man, it's a lot of work.
And
Thanks.
I would also like just to build on that a little bit too. So, the experience Heather had, you've had in 2012 versus the experience I had in 2021. And as Rosalind has mentioned, like that time gap has created a wealth of different tests, diagnostic tools, as well as therapies that are actually contributing to longer life, but quality of life. I will always talk about the quality of life because that is really key and important. And so I think, if what I take is called a take-home drug, and so it's not going to be covered as when you are in hospital. So your IVs, your chemos, your radiations, your surgeries, as always, have been always covered. In the last 20 years, even outside of oncology, take-home drugs are becoming more of the popular therapy. In oncology, we're seeing that more and more. And so as we have access to more tools, as we have access to more therapies and more coming to market, the red tape and the policies that are in place right now are for the old system. They're not for the innovation of today and tomorrow. And so we need to think about how does our systems and policies keep up with approval so we aren't waiting 2 years. There's a lot of really cool experiences and policy changes that are happening in the UK and Australia around how they can shift and work and gain evidence. I think it's like evidence build track, and you're gaining evidence in order to build for a case. But if you see it being effective, you see great results, you can work and patients can still access this as you're still building the case for broader funding. And so I think we just need to encourage and work with people across the regulatory space to say, how can we keep up? Because those policies and regulations in place are for a system that is no longer, and it shouldn't be. And so I would love to see more there. Access to all of these diagnostic tools and therapies need to be today, not 2 years from now. So
yeah, that's really interesting. I'm watching time. I will say there weren't per se questions that were asked. A lot of people, as you guys probably saw, were very early on addressing, hey, there's a discrepancy here. In my experience, there's discrepancies between what's covered where and what tests get done. And a lot around like how do we make those decisions in Canada? And so I'm hoping that people did get, as Rosalind in particular kept going, I think more and more of your questions sort of got answered through that. I'm going to ask Gloria to pull up the slide deck so we can wrap things up, because this is just a point in time. The conversation doesn't end here. And so I want to make sure that I give people the opportunity to understand what happens next. We have an evaluation survey, of course, and we really do use that information directly to inform what we do next. So next slide, Gloria, please. Keep going. Next one. So, yep, back one. Thank you. So I'm going to ask Hasna in the chat again to put in the link to the letter, if you so choose, in terms of putting in your postal code and sending things to your local media. We will also include this link in the email that's probably already in your inbox that has a link there so you don't forget, or if you'd like to forward it through your networks as well to say like, hey, raise your voice here. Here's a simple way to be able to just kind of put a bit of an exclamation mark in your community in terms of the importance of talking about this issue. There's lots of ways to stay connected with us through our social media, joining our networks. There's links that have been provided in the chat to do that. Through that, you can become an advocate, share this session. There will be a recording that is circulated to people that attended. And then it'll be up on our website as well. And so this is a great way that you can say like, hey, take a look at what Heather, Katie, and Dr. Jurgens had to say on this issue. And so that's always going to be really important. We're always looking for patients to help us when there are drug submissions. As a patient advocacy organization, health charity, we are able to compile input into that drug approval process on behalf of people living with, in this case, lung cancers. And so we're always looking to grow that out. So join our network and let us know that's what you're interested in. On our website, we have lots of tools. We have support groups for people with living with lung cancer. Our virtual fitness for breath, the spring session is open right now. And we've worked with an oncologist who has said that it's an absolutely appropriate and beneficial program for people with lung cancer as well. And we're going to be launching soon our lung cancer peer support program, where you can link up with people like Katie and Heather and others to kind of build that movement and get the support that you need. So with that, I just want to thank our panelists, thank many of our patient advocates that I know are on the call from across Canada and the snowbirds in the US, to thank you, because we couldn't do what we do without you. And for all of those that are part of the Lung Health Foundation family and joined us today, and those that are just getting to know us, thank you so much. Our next, third and final series is in April, where we're talking about youth vaping and the crisis in Canada. So we do encourage you to help promote that and join us in that effort as well. So, and with that, I will thank you, and we will end here. Have a good rest of your day.